Good evening and welcome to another great session of IPDLN 2020. My name is Michael Schul and I'm going to be the host tonight. I'm from ICES in Toronto and the University of Toronto, and the title of this session is Cardiovascular Disease Abstracts. We have 4 presentations tonight. Each will be 10 minutes followed by 15 minutes of questions. So the questions will come at the end after all of the presenters have finished. I would ask you to enter your questions into the chat function. You'll see there's a Q&A function at the top of your screen, and you can enter your questions at any time during the presentations, but we will only be handling them or answering them at the very end. So I'm pleased to introduce our first speaker, who is David Ong, a PhD student from Monash University in Melbourne.
Thank you, Michael. Stroke is a major cause of mortality and morbidity, and accounted approximately for 5.5 million deaths around the world in 2016. According to the World Health Organization, stroke in combination with other cardiovascular diseases were responsible for almost 1/3 of all deaths in 2012. More specifically, in Australia this year, almost 27,500 Australians experienced a first ever stroke with almost 445,000 survivors of stroke living in the community. Stroke frequently reoccurs after a prior stroke, and the case fatality rate at 1 year is almost doubled that compared with the initial stroke event. Furthermore, almost half of survivors of stroke will go on to experience another vascular event within 10 years. This highlights the importance of preventing the mortality and morbidity that comes with recurrent stroke. The Stroke Foundation promotes adherence to secondary prevention medications as part of their clinical guidelines. In fact, an estimated up to 9% of all cardiovascular events have been directly attributed to poor adherence to medications, and so there are opportunities to reduce these further vascular events. General practitioners are integral to providing management of chronic diseases, including stroke and other conditions that are expected to persist for at least 6 months. Included in this service are Medicare-funded chronic disease management plans. Chronic disease management plans involve an assessment of the patient's health and discussing actions to be taken, forming an agreement for management goals, identifying services needed to meet these goals, and arranging to review this plan at a later date. However, there is limited evidence of its effectiveness in the Australian population with stroke towards improving adherence to medications. As regular reviews with a GP may enhance adherence to secondary prevention medications, we aim to determine whether a longer duration on a chronic disease management plan was associated with adherence to recommended secondary prevention medications after stroke. For this study, we included survivors of stroke or TIA from the Stanford study. Similar to an as-treated approach of intervention studies, exposure was the use of chronic disease management plans up to 3 years after stroke. I calculated exposure to a chronic disease management plan based on the cumulative amount of time each participant was on a chronic disease management plan, which was based on the minimal claiming period of each of the 5 CDM items listed in this table. We used a similar method to determine our measure for medication adherence, known as the proportion of days covered. Simply, exposure to each medication was determined for each dispensing based on the number of medications dispensed. These dispensing data were then collated for each participant under the categories of antihypertensive, lipid-modifying, and antithrombotic medications. So a PDC of 85% would mean that a participant was dispensed enough secondary prevention medications for them to have taken it for 85% of their time over the 3 years. From the third example, you can see that we have adjusted for death as the person was likely adherent until their time of death. We can see from the last example that any unused medication supply was combined and carried over, unless this went past the 3-year cutoff. Overall, the median adherence to medications over 3 years ranged from the highest in users of antihypertensive medications at 95% to 92% for users of lipid-modifying or antithrombotic medications. Good adherence is normally classified in the literature as having a PDC of 80% or greater, which in our study ranged from 75% of antihypertensive medication users to around 65% for both lipid-modifying and antithrombotic medication users. I then conducted a multivariable logistic regression using good adherence or not as the binary outcome variable for each medication class. Please excuse these small forest plots. The dotted line of no effect is indicated for each model. Using logistic regression with adjustment for potential confounders such as age, sex, stroke severity, and comorbidities prior to stroke, we found that increasing duration on a chronic disease management plan was associated with being adherent to secondary prevention medications at 3 years in users of antihypertensive drugs and antithrombotic drugs, but was not as important for users of lipid-modifying drugs. Also, we found that it was important to adjust for pill burden in the year prior to their stroke, as participants would be more likely to have a higher proportion of days covered if they had a history of being dispensed more medications up until their stroke. Some limitations of this study included the fact that the study was only specific to stroke and that patients were estimated to have taken their entire supply for each dispensing of medication, but this couldn't be confirmed. There are several strengths for this study. First, we had clinical diagnoses of stroke or TIA for each participant. We had rich data on an array of demographic and biochemical risk factors at baseline, such as socioeconomic status, blood pressure, cholesterol levels, and BMI. Our data linkage arrangement gave us access to information of up to 5 years prior to the stroke of use of chronic disease management plans, medications, and comorbidities. Increasing duration on a chronic disease management plan was associated with being adherent to secondary prevention medications at 3 years in users of antihypertensive drugs and antithrombotic drugs, but was not as important for lipid-modifying drugs. Chronic disease management plans for longer appeared to be beneficial for survivors of stroke in terms of improving adherence to antihypertensive and antithrombotic medications. Future studies involving these plans should address whether they are cost-effective. A larger data linkage study using cross-jurisdictional data between 2 states of Australia, Victoria and New South Wales, will be able to investigate this further with greater power and certainty in our findings. Thank you. I would like to acknowledge my supervisors and the investigators, students, and staff involved with the Stand Firm study. Also to the NHMRC, Monash University, hospitals, and data linkage service providers, the Centre for Victorian Data Linkages, the Sachs Institute, and the Australian Institute of Health and Welfare. Thank you.
Okay. Thank you very much, David. That was terrific. And you came in under your allotted time, which is terrific. Leaves more time for questions. So I'm going to introduce our second speaker now. She is Dr. Amanda Eng. Dr. Eng is a research officer at the Centre for Public Health Research. And where is she now? Oh yeah, she's at Massey University in Wellington, New Zealand.
Hi, yes, thank you, Michael. The study I am going to talk about today looked at occupational exposures and ischemic heart disease using the entire New Zealand population. Sorry, I just think I selected the wrong one. Let's try that again. So the background, CVD is a leading cause of death in most Western countries, including New Zealand. Work-related risk factors are often overlooked, despite studies since the 1950s showing associations with cardiovascular disease. The most studied risk factor has been psychosocial factors, particularly models of job strain and job stress. However, there is also moderate associations found for shift work and loud noise, and some evidence for long working hours and sedentary work as distinct from sedentary behaviour outside of work. So our research question was, are occupational exposures associated with IHD? And we used the integrated data infrastructure, which is managed by Statistics New Zealand. And that is a whole population longitudinal meta data set, which consists of routinely collected data from government organisations, Stats New Zealand surveys, as well as non-government organisations. And the different data sources are linked to individuals using what is called a spine, which comprises births, tax, and visa data. And that basically aims to cover the entire resident population of New Zealand. The study design was a prospective cohort study, and the study population was all New Zealand residents aged between 20 to 64 years, employed at the time of the 2013 census. And from that census, we had job title data, which was coded up to the 5-digit level, as well as information on how many hours people worked per week. We also assessed sedentary work, loud noise, and night shift using 3 job exposure matrices, which we developed. So that basically involved 2 to 3 experts going through all of the 5-digit job titles and assigning an exposure level based on a number of different data sources, including previous workforce surveys that we've conducted, overseas job exposure matrices, including the FinGem and a US noise gem, which had actual exposure measurements for that. So just to recap, we used the 2013 census, applied job exposure matrices for 3 out of 4 exposures, and using 2013 as the baseline, we looked at who developed IHD over time up until the end of 2018. And our definition of IHD was using the routinely collected health data in the IDI, the mortality data set, pharmaceutical information, and publicly funded hospital discharges. Lost to follow-up was assessed using deaths from other causes from the mortality collection, as well as border movement data. So ascertaining loss to follow-up was a lot easier using the IDI compared to the previous studies that we've done. And just as a bit of an aside, we have another study, which is part of the wider study, where we loaded our own workforce survey data sets using an ad hoc load into the IDI and used the same methodology to see who developed IHD over time, but I won't be talking about that part today. So the definition of IHD using routine data was based on previous definitions of other studies in New Zealand. And we basically used a combination of data sets and ICD codes for coronary heart disease from the mortality data set, as well as publicly funded hospital discharges and procedures. And using the pharmaceutical data set, we could look at community dispensings of anti-angina medication. And the date of first IHD event was recorded for each case. So we did a survival analysis using Cox proportional hazards regression, adjusting for age group, socioeconomic status using an area-based deprivation index measure, smoking status, and ethnicity, all of which were available from the census. And this is just a disclaimer that we are required to present for all output from the IDI. And apologies for the amount of information in this table, but basically about 41,000 people were excluded who had an IHD event or died from another cause or moved overseas before the baseline date. And there were about over 2 million IHD-free individuals at baseline, and over the follow-up period of 2013 to 2018, there were approximately 30,000 IHD cases. After excluding individuals with no job code, we had 796,500 IHD-free males with about 15,000 IHD cases, and a slightly smaller number for females with almost over 5,000 cases. And the median follow-up was about 5.8 years for both sexes. The majority of cases were identified through hospital discharges, with about 15 to 20% from the pharmaceutical data. So for males, these are the fully adjusted results. For sedentary and noise, the exposed categories are based on more than 50% of workers in those jobs exposed at these levels. So approximately 13% of males worked in the 55 plus hours category, and the reference was 35 to 45. And as you can see, there were no significant associations, which was the same for sedentary work. There was a reduced risk for the higher levels in the age adjusted models, but not after adjusting for further covariates. Approximately a quarter of males worked in jobs where more than 50% of workers were exposed to levels above 85 decibels. And there was a slight increased hazard ratio for the highest category, which was above 90 decibels. For night shift, there was a slight increased risk in the highest category of more than 30% of workers in that job working night shift. For females, again, there were no significant associations for working hours or sedentary work. There were approximately a very small percentage of females worked in really noisy jobs, and there were too few cases in the highest category as well. However, for night shift, there was a higher risk for the lowest category and for a modestly elevated risk for the highest category. So the limitations, we only had data in one point at time with no job duration information. We had a relatively limited follow-up period. Our definition of IHD did not include private hospitalizations or any primary care information. There is private hospitalization data in the IDI, but it's incomplete, whereas there's no primary care information in the IDI. And it was based on health service contact only. So, and we know that there are differences in access to health services by gender and by ethnicity. There are some limitations with using job exposure matrices as an exposure assessment tool. Particularly, it just assumes that a job title is homogeneous in its exposure when there could be differences by task or by industry, as well as gender and ethnicity. And we were unable to adjust for potentially important confounders such as diet and leisure time physical activity, as well as some metabolic factors, although adjusting for BMI and hypertension, high cholesterol could be a form of over-adjustment if it is on the causal pathway. And yeah, however, the study was of the entire employed population of New Zealand, which meant we had sufficient study power and we were able to look at males and females. IHD was ascertained from routine health records versus self-report. We were able to look at pharmaceutical data and not just hospitalizations. And the use of New Zealand-based job exposure matrices was an advantage versus self-report data. And it was easy to identify those lost to follow up with everyone being linked in the IDI. So in summary, we found that night shift work was associated with IHD for both men and women, and a modest association was observed for occupational exposure to high levels of noise for males. However, the study does not support sedentary work or long working hours as risk factors for IHD. And this is our study team in New Zealand. And thank you.
All right, terrific. Thank you very much, Amanda. That was awesome. Also came in on time, which is great. So our third speaker is Dr. Ben Su. Dr. Su is an epidemiologist and health service researcher from the Center for Big Data Research in Health at the University of New South Wales in Sydney.
Thanks, Michael. So this talk was on the use of aged care and hospital services in Australia after new onset of cardiovascular diseases. So as we know, cardiovascular disease is the leading cause of death amongst the older population worldwide, and this includes MIs, myocardial infarction, stroke, and heart failure. As we know, improvements in guideline recommended interventions for these diseases and conditions have revolutionized management and improved clinical outcomes. However, current literature does show that older patients that are discharged from hospital with the diagnosis of MI, stroke, and heart failure are at an increased risk of being admitted directly to residential care or nursing homes. And subsequently, there are serious complications associated with these conditions, which may result in rehospitalization. However, there are critical knowledge gaps regarding the trajectories of service use following these hospital admissions for cardiovascular disease in older patients. And this is important to identify to allow health and social service planning to optimize quality of life and maximize aging in place. Because as we know, older people prefer to remain living in the community rather than in residential care, because this enables them to maintain independence, autonomy, and connection to friends and families. So the overarching aim for this study was to describe the trajectories of use of aged care and hospital services in the 12 months after index hospital admission for MI, stroke, and heart failure, and to quantify the risk of commencing use of community care and residential care services compared to the risk of the general community. So we use data from the 45 and up study. So the 45 and up study is a large cohort study here in Australia with over 267,000 participants, where they were randomly sampled from the Medicare Australia enrollment database. At baseline, the cohort was able to collect a wide range of self-reported social demographic and health questionnaires, and we managed to link the cohort to a series of health administrative data sets, including hospital admission, death registry, and use of aged care services. So we identified MI, stroke, and heart failure through the admitted patient data collection, all-cause mortality through the registries of births, deaths, and marriages, and the aged care services through the National Aged Care Data Clearinghouse. So just a little bit detail in terms of the aged care services here in Australia. So at the very low level, we have the home support only. So these are generally for people who are managing quite well at home, but may want some assistance here and there. And then followed by a much higher level, long-term support. These are the home care packages. And finally, we have the permanent residential aged care, also known as nursing homes or care homes. So as I said, the study population is comprised of people above the age of 45 who do not have a record of hospitalizations for MI, stroke, and heart failure in the 2 years prior to completing the baseline survey. We then identified all the individuals with the index hospitalizations with their primary diagnosis of MI, stroke, and heart failure during the follow-up period, and who had not used any of the aged care services in the 12 months prior to admission. So initially, we described and visualized the sequences and transitions of service use by quarter or 3 months intervals in the 12 months following discharge from the hospital. And we developed Sankey plots to visualize these trajectories and transitions. So the service use states were having no service at all or rehospitalized commencing community care, entering residential care, or death. And then following that, we constructed a comparator group matched 3:1 on sex, age, and no use of aged care services in the 12 months prior to the admission date for each of the relevant index patient. We estimated hazard ratios using Cox regression analysis for commencing community care or entering residential aged care within 3, 6, and 12 months for patients hospitalized due to MI, stroke, and heart failure compared to the comparator groups. And this model was initially unadjusted, then further multivariable adjusted for age, education, households, country of birth, and marital status. So here's a table. This is the baseline descriptive characteristics for patients admitted with MI, stroke, and heart failure. And we can see that in general, there's a mean age about above 70 for across MI, stroke, and heart failure. Larger proportion of the patients were male, were Australian born, and had an education level below university level. The majority were in the lower income category and was married or had a partner at baseline. And this is the figure, the Sankey plot showing the transitions in service use by quarter for 12 months post-discharge for MI and stroke and heart failure. So in yellow is the no service, green is rehospitalized, blue is community care, purple is residential care, and red is death. So it's in Q1, Q2, Q3, and Q4. So just some numbers that you might be of interest. So the use of services within the 3 months following discharge for residential care was 2% for MI, 9% for stroke, 5% for heart failure. And likewise for community care within the first 3 months, it was 10% in MI patients, 17% in stroke, and 17% in heart failure. And in terms of rehospitalization within the first 3 months, it was 26% in MI, 15% in stroke, and 28% in heart failure. And then a further look at, for those that survived the first 3 months, how many of them were using these services at the end of the 12-month post-discharge period. So it was 4% for MI patients using residential at the end, at the 12-month period. Likewise, 17% in stroke, 12% in heart failure. In terms of community care for those who survived the first 3 months and was using community care at the end of the 12-month post-discharge period, it was 19% in MI, 33% in stroke, and 35% in heart failure. And when I also looked at the number of percentage of patients that was rehospitalized at least once over this 12-month period, it was actually at MI patients, was 46% of MI patients was rehospitalized once, 33% of stroke patients was rehospitalized once, and 45% of heart failure patients was rehospitalized once. And these are the tables showing the hazard ratios of commencing community aged care or entering residential care at 3, 6, 12 months after MI, stroke, and heart failure. And as expected, patients with these conditions were at an increased risk of commencing community care or entering residential aged care. And not to our surprise, stroke patients had the highest risk of nearly 3 times the risk of entering residential care and at nearly 2 times the risk of commencing community care. So just some few discussion points. So as our research shows that this older cardiovascular disease population is particularly vulnerable to transition-related risks, leading to hospital readmissions, commencing community care, entering residential aged care, which may subsequently lead to increased healthcare costs, reduced quality of life, and increased family burden. So the transfer from hospital to home or residential care facility is a vulnerable period in the continuum of care of older adults, as the care transition is quite frequent and risky for older adults, particularly for those with frailty and multimorbidity. So the integration and access to primary care, allied health, or other health support services is quite important to ensure the continuity and coordination of healthcare when patients are actually transferred across these care settings. This supports older cardiovascular patients' reintegration back into their everyday routine, everyday activities, and improve their quality of life. So we do believe that primary care and these other health support services is well placed for the care of older people, as it has the strength of a multidisciplinary management focus on secondary prevention and the knowledge of patients, including their social context and capacity of ongoing chronic disease management. So just some strengths and limitations of the study. So obviously this is a large cohort study with a large sample size. We were able to link it to a series of health administrative data sets, which provided a comprehensive ascertainment of CVD hospitalizations and the use of government-funded aged care services. However, some limitations is that this linked data did not capture the use of self-funded aged care services. So there might be periods of no service use, which in fact was represented by periods in which self-funded aged care services were being used. And finally, that as a result, some of the indexed hospitalization may not have been the first hospitalization, since some of the members of the study population may have had a previous hospitalization due to MI, stroke, or heart failure prior to our 2-year exclusion period. So just to conclude, our findings show that there is a significantly elevated hazard of commencing use of community-based and residential aged care services, where most of these individuals who commence these services continue to do so at the 12 months post-discharge. So better coordinations of cardiac and stroke rehab and secondary prevention targeted for these settings is warranted to improve quality of life, reduce rehospitalization, and maximize aging in place. Finally, I'd like to acknowledge my supervisor, Professor Louisa Jordan, the New South Wales Health Central Coast Local Health District, for funding this project, the Sachs Institute and its major partner for setting up the 45 and up study, and the Center for Health Record Linkage and the Australian Institute of Health and Welfare for helping us out with the data linkage, and last but not least, the thousands of the 45 and up study participants. Yeah, thank you.
Terrific. Thanks very much, Ben. All right, and our last speaker tonight is Ms. Rebecca Seth. She is a data analyst at the University of Western Australia.
Yeah, thanks, Michael, and thank you everyone for coming to the session today. I'm going to give you an overview of the methods we have developed while using multiple data sources to characterise the burden of acute rheumatic fever and rheumatic heart disease in Australia. I'd like to start by acknowledging the traditional owners of the land that I'm presenting from today, the Whadjuk Noongar people, and pay my respects to the elders past, present and future. So rheumatic heart disease has its roots in infectious disease. It starts with a strep infection of the throat, and through an autoimmune reaction, acute rheumatic fever causes damage to the heart valves, which can lead to heart failure and death. It's been eradicated from most of the developed world, but unfortunately here in Australia, there are still very high rates in our Indigenous population. And because of the extreme disparity in RHD prevalence and the need for better prevention, the End Rheumatic Heart Disease Centre for Research Excellence was formed in 2015, with the aim to produce a roadmap of actions to be taken to remove RHD as a public health problem in Australia. So as part of this initiative, there was a need for good epidemiological data as a baseline for planning, monitoring and engagement, and that's where our study comes in. The End Rheumatic Heart Disease in Australia Study of Epidemiology, or ARRAISE study, was formed, led by Dr. Judy Katzenellenbogen, with the aim of providing reliable burden estimates to use, mainly through the use of linked health data. So the study includes multiple jurisdictions and multiple sources of data to provide information in stage 1 of the study about the incidence and prevalence, and that's what I'll speak about today. But before I get into the details, this project really has had so much input from so many people that I'd like to acknowledge them here, especially the peak Aboriginal health organisations from each state, the data linkage units and custodians, and the extensive study team and all of the investigators. There are 3 main data sources used in the study, and they are hospital admissions, death registration data, and RHD registered data. The RHD registers are records that are maintained by each jurisdiction to monitor the secondary prevention of rheumatic heart disease following an initial episode of ARF in an individual. In addition to these data sets, there are many ancillary data sets linked into the study as well. Shown on the right, we also have available emergency department data, cardiac surgery databases for both pediatric and adult, as well as some primary healthcare visit information for about 40% of the Northern Territory. And we also have maternity notification data being currently linked in. The process of applications and data acquisition took 2.5 years. And in Australia, the data for every jurisdiction is unique and needed to be cleaned separately and then harmonised into a single data set to produce the quasi-national estimates. So when it came to defining and identifying rheumatic heart disease cases, there were a couple of challenges. If we were to use only the hospital data, then we would undercount because not all of the diagnosed cases will be admitted to hospital. We can, however, capture additional non-admitted cases by using the RHD registers as well. And identifying RHD cases using hospital admissions was also an issue due to non-specific ICD codes that can default to an RHD code even when the underlying issue may not be a rheumatic heart valve. So if we included all of these codes, we would overcount substantially the number of cases. However, these records do also include true cases, so we would undercount if we did not include them. So to overcome this, my colleague Daniela Bond-Smith developed a prediction algorithm which uses a generalized linear mixed model. This is an overview of the algorithm, which has been published in Clinical Epidemiology earlier this year. To train the model, we used gold star validated cases with known positive or negative diagnosis of RHD. And these cases came from RHD registers and surgical databases, as well as some linked in case audit data for Western Australia and a validation study done in Queensland. When applying the prediction model, we use longitudinal information from the hospital admission records, as well as demographic variables and clinical history to assign an algorithm score and give each RHD coded hospital record an RHD negative or RHD positive status. This figure shows how we identified prevalent cases of RHD using multiple data sets and our look back period. The green line is the hospital data, yellow is the register data, and red is the surgical data. So for example, person 1 here has only hospital data available, and the blue crosses indicate algorithm negative admissions and the purple are algorithm positive admissions. So whereas person 2, you can see that they have 3 sources of data. So they're present on the surgical databases, the register and the hospital. So to determine overall if someone was a prevalent case, we just appended all of their positive and validated dates from the multiple sources. And if a positive diagnosis occurred during the look back period, then that person was counted as an RHD case. When defining the acute rheumatic fever episodes, we use the standard which has been established previously, which is to count a record as a new episode if it occurs more than 90 days after the previous ARF record. This is necessary to avoid double counting because the sequelae and hospitalizations for an episode can be drawn out over a month or more. And we're also able to use both hospital and register data, which it will be recorded on both the episode in some cases, and just adjust because we were using linked data. So this diagram here shows an example of 6 records for ARF from both hospital and register for a single person, and how we've defined them as the first ever episode in that person, as well as 2 recurrent episodes using the 90-day rule. So this is an overview of how we formed a cohort from the data that we had. The outer big circle is all of our data from the data generating cohort that we received, with many false positives likely for rheumatic heart disease. The smallest one is our registered data with all of the validated cases. And in the middle is the analysis cohort we created by combining the data sets and using the algorithm to flag positive hospital records, and also restricting the cohort to less than 55 years old. Well, this map shows the states and territories of Australia, and the grey shaded areas are the jurisdictions we had data for. But because there's a lot of heterogeneity within each state between metro and rural areas, we wanted to be able to report the incidence and prevalence rates for smaller regions as well. So we decided to report by the Indigenous regions shown in the map here, which are used for statistical reporting by the Australian Bureau of Statistics. And these regions are defined based around the locations of Indigenous populations. So out of the 38 regions, our 5 jurisdictions covered 33 of these regions. And across the data that we received and the data sources, we had different geographical variables available. The most common was postcode. However, when assigning regions, not all postcodes map directly to a single region. For example, a single postcode might be split 20% of region 1 and 80% of region 2. So in this case, to our data set at the person level, we assigned region 2, which was most likely because it was 80%. But for the case numbers and rate calculations, we took a probabilistic approach and assigned 0.2 of a case to region 1 and 0.8 of a case to region 2, just in order to avoid systematic biases in the assignment geographically. So once we had mapped the individuals to regions and we had defined cases of ARF and RHD, this is an example of the results that we were able to produce. So this map here shows the annualized average ARF incidence rate for Indigenous people under 45 years old from 2015 to 2017. And I'm showing only the Indigenous here because the rate ratio was about 120. By the current gradient, we can see the highest rates in the northern regions and rates are lowest in the southeastern regions of Australia. And being able to report results at a sub-jurisdictional level has been really useful for reporting back to communities and also for targeting interventions. So how are we using the results that we have now? Well, they have been used in the evidence base for new guidelines to inform policy, as in the report published recently by the Rheumatic Heart Disease Centre for Research Excellence. And we are also disseminating the information to Indigenous stakeholders to facilitate action and uphold data sovereignty principles. Using linked data, we were able to produce better definitions of ARF and RHD within administrative data that is reliable, and it will be reproducible in the future in order to monitor whether these preventions are having an impact. And it hadn't really been done before. We were kind of unsure about the overall burden. And now we have generated this really well-defined cohort, and we have lots of ongoing projects that use this cohort, including a costing analysis. We're looking at surgical outcomes, and we're also looking at the progression of disease, as well as many other projects as well. Thank you, everyone.
Okay, that's terrific. Thank you, Rebecca. All right, so all of you gave terrific presentations, and you all stayed within your time limits, which is awesome. So we have about 20 minutes for questions, which is great, and I already see a few in the queue. So I'll encourage all of the attendees, there are about 40 of you by the looks of things, to please type your questions into the Q&A box, and we'll do our best to get to as many of them as we can. And I will read out the questions to you. Some of them are actually directed specifically at individual presenters, and others maybe more general. So let's start with the first question here for Amanda. It says, very interesting study, and amazing that you can use the whole of New Zealand data. Given the association between night shift and ischemic heart disease, I was wondering what you think could be done to minimize risk. Should people with other risk factors be advised to avoid night jobs? Is the shift loading enough of a compensation?
Oh, that is a very good question. Obviously, more research is probably required. The ad hoc load data that I talked about briefly did look at some cardiovascular disease risk factors did differ by occupational groups, not by, we didn't look at night shift per se, but yeah, I'm a bit hesitant to say that people with risk factors should avoid night shift at this stage until we do more research. Yeah.
Okay. Next question. This one's for Ben. It's the question is, I'm particularly interested in your method for determining entry to aged care. were you able to ascertain whether patients were already in aged care at the time of their event?
Yeah, so for this study in particular, we excluded anyone who had aged care services 12 months prior to the admission, but then we were able to identify whether they had a hospital admissions during the time period that they're in aged care. So, and another project that I'm working on at the moment, which is looking at cardiovascular disease burden in older people that are in community aged care or residential aged care, where in that study I actually found that people in aged care, residential aged care, had the highest incidence and also prevalence at entry into these care homes with cardiovascular disease, followed by people in community aged care and then general community. So these are hospital diagnoses, but interestingly, we also look at whether they had cardiovascular disease related interventions while they're in these aged care settings. And then we found that it was the ones that in community aged care had the highest incidence for CVD interventions, whereas people in residential care actually had really low incidence for CVD interventions.
Okay, thank you. I'm going to encourage our audience here to send in some more questions. We have a few, but we have time for more. I have a question actually for David. David, in your study, you looked at, if I understood correctly, the use of chronic disease management care plans and its association with adherence to various medications. I'm curious whether, could there be some reverse causality there? Could it be that physicians who are just more likely to prescribe medications are also more likely then to use the CDM plans? And were you able to look at that in particular? I'm presuming that these chronic disease plans were introduced at some point in time into the billing scheme. Were you able to look before that time at adherence for patients associated with a given physician, and then following the introduction of those CDM plans to see if adherence actually increased?
That's something we can definitely look at, given that our cohort's primarily looking at people with the first ever stroke or TIA. We were interested in their adherence to those medications after their event, but that is definitely something we can look at and potentially adjust for if we find it's important. We had a kind of a proxy measure looking at pill burden in the year prior in each of those medication categories as a way to adjust for that potential source of bias.
Okay, thank you. So we'll take another question from the queue here. This one is for Rebecca. It says, was there a difference between those cases on the RHG register versus those assembled in the hospital data? What do you gain? I guess means what do you gain by using the two different data sources?
Yeah, so thank you. And it's a really good question. Such a good question that somebody did an honors on it for us when we first received the data, just to look at what the exact differences were between cases that are identified on the register compared to the hospital. So there is a paper on it if you're interested in reading it, that I think has been published or about to be published, I'll find out. But the main difference is that the register is more focused on the current epidemic of the disease, so younger people and more Indigenous cases. When we get into the hospital data, we get a lot of older people who perhaps had like a mild case of acute rheumatic fever when they were younger, and it's in their clinical records, and that is why we have restricted our reporting to less than 55 years old. So that is the main difference, yeah. And also, if you're on the register, you're much more likely to have captured your acute rheumatic fever episodes as well. So we do gain a lot by having both put together.
All right, thanks very much. Next question. This one is back to David. It says, David, could you tell us how you determined the number of days someone was covered by a particular medication? Did you use the DD method? Oh, okay, that question just disappeared out of the queue.
Sorry,
So,
it's been answered questions now. I just posted a reply for a reference that I was going to talk to.
So, okay, sorry, do you have an answer to that question then?
So just to finish off that question, they were asking how we determine the number of days someone was on a particular medication. Did we use the defined daily dose method? Did we do any sensitivity analysis around our assumptions? So for this particular study, that was a potential concern where a lot of studies would assume that patients were taking their medications at a rate of 1 per day. So in Australia, with part of the pharmaceutical benefit scheme for subsidized medications, it's generally designed around kind of a 1 month supply. And so we investigated this by looking in a larger data set, particularly the Australian Stroke Clinical Registry. We just published an article recently looking at this assumption, and basically we found that the assumption of 1 dose per day is acceptable in a population with stroke. And so the method that I used in this study was actually based off that data, where we looked at what the 75th percentile of people who were taking each individual medication. We were looking at the 75th percentile of when they would return for a repeat script of that medication. And then that would inform what the 75th percentile of the estimated daily dose people were taking. So rather than just 1 dose per day, we used that much larger study of people with stroke to estimate the dose that patients were taking each medication at. Hope I explained that okay.
Okay, thanks very much, David. Question for Amanda. It says, are there any plans for translation of your findings, for example, surveillance for people working shift work like nurses, doctors, etc.?
Hi, yeah, thank you for your question. It is a good question, and it would be great if surveillance was carried out. I do intend to present these results to WorkSafe New Zealand, who are our health and safety regulator. I think perhaps surveillance would be, if they did do it, would be quite far into the future, but yeah, there's definitely plans to talk to them. And I'm doing some work with the healthcare sector anyway, so I will present results to them as well.
Amanda, I have another question for you. So the jobs you looked at, night shift, exposure, noise, etc. I mean, with the exception of nurses and doctors working night shifts, certainly lots do, but those jobs would often be sort of perhaps more manual labor, blue collar type jobs. Did you control for socioeconomic status, and if so, how? And did the fact that if I understood correctly, you looked only at, or you only had access to data for public hospitals and not private hospitals, what sort of bias might that introduce in your analysis?
So we adjusted for socioeconomic status. It was an area-based measure, which does have its disadvantages based on mesh blocks in New Zealand, which are about, quite small area units. And so that it did attenuate some of the results, but there was still that higher risk for night shift. And I also stratified by blue collar and white collar status, and also observed an increased risk for both. I didn't adjust for occupational group because the original classification of exposures was based on occupation anyway. And sorry, what was the second part of the question?
Well, just the question of if you only had data from public and not private hospitals, does that introduce any potential biases in the analysis?
Yes, previous studies of routine data, not necessarily in the IDI, have tried to estimate how many are captured by, in New Zealand, they've estimated that actually the majority are public hospital admissions. So I think above 90%. Yeah.
Okay, terrific. Next, a question for Ben. Ben, in your Sankey plots where you show transitions between different types of service use, how did you treat people who used multiple types of services? For example, they were within residential care and also had a rehospitalization.
Yep, that's a good question. So in terms of the Sankey plots, we just identify based on a hierarchy. So then people with residential aged care is at the top, followed by community care, then hospitalizations, then having no services. So then, because due to the nature of the data, it's provided by a quarter. So then we just identify within that quarter, we just identify which one is the highest level. And then, but then, although saying that we did look at the number of rehospitalizations among patients that were in residential aged care, and also looked at those that were just in community care, and then calculated their rehospitalization rates as well as the whole cohort, that what was their rehospitalization rate. So, but then obviously that wasn't shown in the Sankey plots, but then it would be separate.
Okay, we have about 8 minutes left, so I'll encourage attendees to ask some more questions in the Q&A box. In the meantime, Rebecca, I have a question for you. Your study obviously was of particular importance to Aboriginal populations in Australia. I'm just curious whether you can tell us a little bit about if you did any sort of engagement work with Indigenous communities or Indigenous organizations as part of the design of the study or its implementation.
Well, I wasn't directly involved in that part of the study, but I do know that there was a lot of engagement done through the Centre for Excellence, and Rheumatic Heart Disease, and that, yeah, a lot of Aboriginal bodies were involved as well. But yeah, I can't really say too much more on the specifics of what was done. Sorry.
Okay. Well, listen, that's been terrific. I have one last question for all of you, all four presenters. So maybe you can each take a stab at it. And it's a little bit broader of a question, but you know, I think it's fair to say that cardiovascular disease is probably one of the best studied areas of disease with population level or administrative data. It's been an area that's been studied for many, many years in many jurisdictions and quite successfully. And I'm wondering, from your perspective, you're all young, up and coming researchers with great careers ahead of you. What do you see as some of the new frontiers in cardiovascular research using population health data, some of the things that we should have on our minds as the new things we'll see at perhaps the 2022 or 2024 IPDLN conferences? And why don't we start with David?
That's a very good question. I think if we can link with larger registries and more data sets, there's one that I have in mind upcoming. And there's a lot more interesting questions that we could potentially look at. And I think one of the frontiers may be translation into practice. So that's of a big concern to everyone. I think just really looking at if what we're doing currently is effective, cost effective, and reducing hospitalizations and those kind of outcomes.
Okay, terrific. Amanda, how about your perspective?
From my perspective as an occupational health researcher, there is still not enough done, I think, in the occupational health space. And one of the things we also wanted to do was look at the combination of different metabolic factors as well, when looking at exposure and IHD. So what role does diabetes play? What role does hypertension, high cholesterol? But unfortunately, the data wasn't good enough in the IDI to do that. So that's something that I would like to do, kind of the causal inference modeling, looking at all these different factors. So yeah, that's what I think would be interesting. And also in the IDI in New Zealand, the addition of primary care data would be hugely useful as well. Yeah.
Fantastic. Ben, your thoughts?
Yeah, so as some of the researcher who's interested in aging in particular, I would say that because at the moment, the guidelines for cardiovascular diseases is actually more targeted for the general population and doesn't really target it in terms of taking into account age or geriatric syndromes. So it would be of good use of these health administrative data sets eventually linked to other pharmaceutical claims data or outpatient data or electronic medical record, and to really identify whether the current guidelines for CVD is actually appropriate for currently managing these older adults, or should be any changes to the current guidelines which are targeted for these older populations. So I think that might be somewhere that we could move towards in the future.
Great. And last word to you, Rebecca.
Thanks. Well, I think that we need to continue to develop methods of using the linked data so that we're able to interpret administrative data as closely to approximate it to like what happens clinically. And I agree with David, what he said about linking in more data sources, because I think when you do that, it does allow you to do these methodological analyses. And at the moment, actually, my colleague, Daniela Bond-Smith, is doing a really interesting project which on the LinkedIn primary healthcare data that we have just for 40% of the Northern Territory. And she's comparing this, primary healthcare data to what we're seeing on the registers and on the hospital data as well. And we're going to be able to get some very interesting insights specific to acute rheumatic fever and rheumatic heart disease from that data.
Okay, thanks very much. All right, well, that is all the time we have this evening here where I am, and this morning where you are, or afternoon. So I hope you'll join me in thanking all of the speakers. I think you did a great job. It was a great session. The recording of this session will be available on the conference platform in about 48 hours time. And if you enjoyed this session, you may also be interested in today's featured on-demand videos and posters, and you can find those in the on-demand gallery. So I wish you a great rest of the conference, and look forward to meeting you guys in person one day in the future. Bye-bye.